I'm going to turn this over to Dr. Meg McNamara to introduce our speaker for today. Meg?
Thank you, Dr. Hirsch. And it's my great pleasure and privilege to introduce our speaker today. Dr. Mark Galley was appointed in 2019 by Governor Gavin Newsom as Secretary of the California Health and Human Services Agency, overseeing California's largest agency dedicated to healthcare and safety net services. Dr. Galley earned his MD and MPH from Harvard, and we had the good fortune of getting to know Dr. Galley through his time in residency training here at UCSF. He graduated from the PLUS program in 2005. And from there, he became medical director at the Southeast Health Center, where he practiced pediatrics and led a transition to the patient-centered medical home model of care. In 2011, Dr. Galley became the Deputy Director for Community Health and Integrated Programs for the Los Angeles County Department of Health Services. There, he directed clinical operations in the juvenile detention system and led the transition of health services into an integrated system. He also led a team to expand services on the Martin Luther King Jr. Health Campus, including opening the community hospital there. He's married to Dr. Christina Galley and has 4 young children, and it is quite impossible to imagine how you have balanced all of those things and how you've managed this incredible task of bringing our state through this past pandemic year. And we are delighted to have you with us and look forward to hearing your remarks this morning or this afternoon. Thank you.
Thanks, Meg, and really fantastic to be back at UCSF with all of you to share a little bit of time. I always think fondly of my time in residency and the mentors and individuals who've shaped my career, and hopefully I've been able to give back even a little bit to some of you and others to come, and really just a privilege to work with you across the state, your other UC colleagues, other pediatricians, other health professionals, other committed civil and people servants that have done so many heroic things in the last year. And just grateful to the residents in particular for rolling up your sleeves and doing things in a time of uncertainty in such a high integrity and dignified way. And just grateful to have a few minutes with you to share. When Meg reached out, I had thought originally, hey, we're just going to talk about the pandemic. We're going to talk about the response. We're going to share a little bit about the lessons learned and hopefully some conversations about leadership. And I'm always happy to have those as well. But where we find ourselves in the last few months with this unusual opportunity, and I often have been talking about COVID as the great unmasker of disparities, but also the great accelerant of change. And I firmly believe that in a handful of years, we'll look back at COVID, not only lamenting and being concerned about what we lost, but also focused on what we have gained and the opportunities that we have moving forward to transform the lives of so many individuals who got through the pandemic, but really had needs exposed. And I can't think of an area more appropriate to talk to you all about, but frankly, it's been the area I focused on for the last many months, which is children's behavioral health. So if you'll indulge me, I want to sort of walk you through what we're thinking about at the state, hopefully take some of the questions that you have at the end, but then also challenge you to be part of what is coming. So give me a moment. So hopefully you can see my slides okay. And, really, I think an opportunity to do just this, chart a new course for children, youth, and young adult behavioral health in California. And like so many things, really a post-pandemic opportunity. I wanted to just spend a few minutes talking really quickly about things I think most of you know even better than me, which are the trends in mental health and substance use disorders for young people, talk about COVID's impact, hopefully teach you a little something about how the state budget process works, and specifically Health and Human Services, because I've always been impressed how many opportunities we miss as pediatricians to impact that. And some of you have heard me talk through this issue before, but I'll do it again quickly and then go into the meat of what we're proposing as part of this budget from what the governor's proposing, but really depending on my agency to deliver. So, you know, this is not a new issue. We, even before the pandemic, have been seeing needs for young people escalating when it comes to behavioral health. And I intentionally use behavioral health to include not just mental health issues, emotional health issues, but substance use disorder issues as well. So just some quick understanding of what we were dealing with before. 1 in 8 teens reporting major depressive episodes. In 2014 to 2015, that was up from a few years earlier. The number of young people, 12 to 17, who needed help on emotional mental health conditions, basic things like feeling sad, anxious, or nervous. A full quarter of our patients, young people, feeling that those emotions up significantly in 2018 from a few years prior. That 1 in 13 kids in California experience serious emotional disturbances, enough that they qualify for IEPs, that they are getting support in hopefully systems that are culturally competent and able to meet their needs, but we know that many don't, even though they're diagnosed. Hospitalization rates going up pretty quickly. Pre-pandemic, we saw a pretty radical increase over, you know, the early 2000s and up till 2020. And the fact that even though needs grew, treatment did not. The amount of caregivers, the amount of treatment programs available did not grow at the pace of our ability to recognize it, the issues among young people, and the fact that we continue to see a widening gap in our ability to support young people with behavioral health needs. We often talk about suicide, self-harming behavior. We know that it's second leading cause of death among young people, but a major driver of the increase in hospitalizations, the just suicidal thinking increasing pretty dramatically over 2013 to 2017, and really just calling out, and as a father of 2 young girls, 1 teenager, concerned, of course, about what this means between girls versus boys, and the fact that girls are impacted so much more. And that stat of 1 in 9, I think, for all of us who take care of panels of patients of young girls, young women, or our parents too, or caregivers too, I think this is always a sobering reminder of what we're up against. Substance use disorder, and I had the privilege of doing a lot of this work in Los Angeles, less in San Francisco when I was there, but I remember being in Bayview as a sort of, taking care of young people, but really at a teen clinic that we started way back when in Bayview, and just feeling so unmatched or unprepared to get young people the help they needed on substance use disorders. We know that over the last year, we've seen a significant increase in the number of young people with substance use disorders. And unfortunately, the fact that only about 1 in 10 who need treatment actually get it. It's a reminder not just of our need to evolve the science, but for what we do know that works, we need more programs that serve those young people. This is always something that I'm impressed by. I can't imagine this being the case for so many of the other illnesses that we end up taking care of, whether in the hospital, the outpatient basis. The fact that 2/3 of adolescents with major depressive episodes don't get the treatment they need. Could you even imagine among diabetics or people with young people with cystic fibrosis that 2/3 go without treatment? I mean, I feel like it wouldn't happen on our watch. We would insist on something changing, but yet we have allowed it to happen one way or the other. And not just we on this Zoom, but the larger collective we. And I think that it underscores the need for action, that we're able to diagnose something but have no answers is of serious concern. I think those who know me know that I spent a good bit of my time working in the child welfare system, especially in Los Angeles, and the juvenile justice system there. And the pressure around behavioral health conditions in both of those systems is not something new to any of you, but something that I think requires us to continue to focus on equity, continue to focus on those who have been overlooked and underserved for so long. And we find those young people, mainly brown and Black young people in the foster care system, in our juvenile justice system, who have significantly higher numbers of behavioral health conditions. And those systems are, again, outmatched, although they do have some providers and networks. The evidence-based practices, the application of those practices is still growing, and we're going to need to do a lot more to make sure that those young people don't fall further and further behind. As I like to say, having worked sort of on the front lines in juvenile halls and camps in Los Angeles, that I hadn't met a young person who felt like their needs were well taken care of in those systems. So how do we make sure that our healthcare delivery systems abut those other systems, make sure that we can provide what we need in those arenas? So we know, and I think many of you probably even had grand rounds about behavioral health and COVID and the impact of young people. We know it starts with their caregivers, the stress and emotional distress that caregivers, parents, guardians have faced, whether it's because of work, because their own sort of social circles have been disrupted. We've seen an incredible increase in anxiety and depression, and that trickles down to the children and those they're taking care of. We know that acutely these stressors affect Black and Latinx communities even greater. The same communities that were ravished by COVID-19 as an infectious disease are also being ravished by the impacts of COVID on mental and behavioral health at large. I was on a call with some of the pediatric hospital leaders, CEOs essentially of those facilities, just a couple of days ago, speaking about this, and wherein there was an overall reduction in emergency room admissions. There was a 35% increase in the number of behavioral health related emergency room visits for young people last year. It supports this JAMA reference here, but that's something that both needs to be alarming and raise red flags, and something that we as a state need to finally do something about. And again, the impact on not just ED visits, but what's happening in our communities. We've talked a lot about the impact of school closures on the disruption of normal routines, and finally those impacts coming to roost in a way with these radical increases in the number of young people who are showing up in our emergency rooms desperate for help, pretty far advanced in their symptoms, and we haven't had the kind of answers I know you all on this Zoom want to see us have. I think it's probably notable, it didn't make it in the slides, but just recently what happened at Denver Children's Hospital, where their director declared a children's behavioral health crisis for their city and frankly this state. And I think we're seeing that all over. We knew back that when we chose to start doing the restrictions statewide, whether it was in schools or other sectors, we needed to do those to protect against the unknown of COVID, but we knew that there would be impact on young people. I'm not sure people expected it to be this long or this long lasting, but we are now facing the reality of those early decisions and the impact that we're seeing today. So just some quickly, I think many of you could do a pretty quick review on this as well, but put pretty simply, kids and young people have been stressed. So much loss of opportunity, loss of those social supports and constructive outlets that no one is going to be surprised that with these unchecked largely, that the struggles have increased around SUD and mental illness for our young people. And we know, just underscoring again, 4 kids, 2 girls, 2 boys, just heavy focus on what this means for young women and girls, and what we can do to make sure our programs are paying attention to their needs moving forward. We often talk and lament the connection between health and schools. I think for all of you, I think you begin to see how your role as pediatricians and health leaders is clearer on how we can address this urgent crisis. But our work with teachers who can and should be promoting mental health among their students, being equipped with the tools, I think is going to be a theme that we work on in California, that we need to enhance children's and adolescents' access to mental health services, not just the face-to-face systems and programs that we saw ramp down, but really amplifying some of the lessons learned during COVID to increase the use of digital platforms to do that initial engagement, that regular off-hour service, whether it's in groups or one-on-one sessions or just an interactive tool that's going to allow a young person to feel a little bit more connected and calm and get through their day. I think these are going to be themes that you'll see in the California plan that we want to see scale statewide. So quickly moving into the conversation about what the state does at this time each year, and to make sure, if you take nothing else from this talk and an opportunity to spend a little time together, this is an important process that, you know, when I was a resident, I knew very little about. I didn't understand certainly the process, let alone how I plugged into it to influence change. So California, the governor just announced this $100 billion California comeback plan. This comes out of the benefits from the federal COVID virus relief funds, as well as state tax revenue that frankly was higher than people expected, even as recently as January. So some important components that people should recognize are part of this large California comeback plan. Lots of cash support, stimulus checks for individuals who are middle and low income, dollars going to support small businesses, not just that had been shuttered and fell behind during the pandemic, but also for new ones that spur innovation. We often talk about California being the next coming attraction, that things get previewed here first. And so much of that's true in Silicon Valley and on tech, in entertainment and other areas, but also a major small business leader. A significant number of new jobs in the nation get created here in California. So spurring that is an important investment. And then I think many of you have seen the impacts on housing and the need for rental assistance and things like job training. So a major investment there. An issue that I have the privilege of working very closely on is a $12 billion investment to tackle the homelessness crisis. Many of us were not out as much to see how it was unfolding during COVID. Things became significantly worse. People lost jobs, lost their homes, found themselves on the street for the first time. And those who were there before the pandemic, some were served by some creative and innovative programs, but many still languished on the streets and have only become more impaired and more in desperate need of help. So being able to focus on homelessness with these investments, one piece that I'm proud of is the governor's bold goal of functionally ending family homelessness. Many thousands of new families have become homeless as part of the pandemic. Some are sleeping in cars, some are couch surfing, others are on the streets and sleeping under bridges, just like many other homeless adults. But the idea of being able to use this portion of this $12 billion to create meaningful exits for families experiencing homelessness has been a really important part of what my agency has been focused on. I think part of the most exciting aspect of the California Comeback Plan is a $20 billion investment to reimagine public schools. A component of this is the $4 billion Children and Youth Behavioral Health Initiative that I'm going to talk about in detail, but I will just highlight another important investment in what are known as community schools, which I'm happy to talk about in more detail down the road, but I'm certainly not the expert. But these are really, in many ways, full service schools, schools that have more than just K through 12 education. I've met schools with laundry facilities and counselors that host food banks and make deep connections to things like transportation and job training. It recognizes the role of school as community hub, that taking care of young children means taking care of the family and all of those needs, and building up things like school nurses and school counselors and school behavioral health professionals, important. Other infrastructure that's being invested, little less about health, but directly tied, broadband, a major issue, and quote, closing that digital divide that we saw the consequences of throughout COVID, and then wildfires, and definitely an important health and public health issue with climate change. So just to kind of tell you where we are in the process, and this is consistent year by year, and I'm learning it more and more every day I spend at the state. So summer and fall, so we'll start it again right after this budget is signed. State departments and agencies like mine begin to prepare proposals, hear from people in the community on the front lines about what we need to do in the upcoming budget, pray that we have dollars to be able to support more programs, but always look to hold on to and improve what we already have. That happens through the summer and fall. I have the privilege of being on a small group of folks who help guide what happens in the January budget. This is known as the governor budget. He releases it on January 10th or by January 10th each year. And then we go into a series of hearings and subcommittee meetings with the legislature to understand what those proposals are, what their intent is, how we're going to be good public stewards of those dollars. Then in May, the governor makes a May revision. And this is often not a major earth-shattering change and shift from what is presented in January. This year, however, it is a major shift. We did not see or know that we would have such a surplus of both federal and local state funds to be able to use to recover in California. So this year's May revision, unlike others, has a significant increase in the number of proposals that are being considered by the legislature. And that's what's happening now. A couple times a day, nearly, I participate in a hearing or a conversation with the legislature to help clarify and understand what our budget proposals are moving forward. And then in June, legislative leaders, the governor, come together, they address any outstanding issues, they reconcile their own budget interests and issues. And then by the 15th of June, budget bill is passed, and then the governor signs the budget no later than the end of the month in June. That takes shape on July 1st and guides the next year. It always has to be balanced, unlike federal budgets. The constitutional requirement to have a state budget that's balanced makes it a little tricky in hard years, but also in years where we have more dollars than expected, choosing the right things to invest in is key. So on to sort of what the Children's Behavioral Health Initiative is and what the proposal is. And really, we recognize that addressing behavioral health for all California's children and youth is vital to our recovery here in the state. And we've moved from this kind of strict response phase of COVID to one where we're really looking at the weeks, months, and years to come as recovery. We know we have a lot to learn from the response, but we cannot discount the need to quickly move with our recovery thinking, as part of what we're doing in this budget reflects that in significant ways. So the goal is to transform California's children and youth behavioral health system into what I like to think of as a world-class, one-of-a-kind, innovative, and upstream focused We know that we often delay care in so many areas, but in behavioral health, as I outlined earlier, we delay care significantly. So being focused upstream and creating a place where all children 0 to 25, all young adults are routinely screened and assessed and supported for needs that emerge. So specifically, as I've said, this is for all young people, not just Medicaid. Our state, my responsibility over Medicaid is clear, longstanding, but we work with partners on commercial health plans in other areas outside of Medicaid to ensure that individuals are receiving the care that they need. And in this proposal, it's almost as though we're going to have a unified system for all young people 0 to 25. The goal is to make sure that all of the parents that take care of our patients and every single patient knows and comes to expect that California will create a system that takes care of their needs with a focus on evidence, a focus on cultural competency and equity, as we've learned. This is a $4 billion 5-year proposal. It is still a proposal. As I said, the legislature will work and communicate with the governor's office and team, including myself, to get us to a final recommendation or final proposal in the budget. But right now, $4 billion over 5 years. This includes $2.3 billion of one-time funding. A lot of that is federal dollars coming in through various stimulus programs, but a significant amount, especially that ongoing funding, is state general fund. Now, you may say, well, compared to 4 billion, 300 million is a small amount, but it is significant. We do not often make large ongoing investments in things like health. We expect a lot of the private system, the federal dollars to pick that up. This significant investment of $300 million, we'll talk about what that gets spent on in a moment. And that gives us a chance to draw down additional federal money to match those service dollars. Those go beyond 5 years. So that's something that we should consider as a reliable ongoing dollar pool to spur ongoing innovation and service delivery. These will be accessible. We'll start with a virtual platform that I'll talk about a little bit more in a minute, and then always focused on the timeliness of care, the fact that we will have not just virtual services, but in person, and build up the resources for the most intensive and acute needs as well. And again, and I keep saying it because it's not usually the way we work, it's not usually the goal at the outset, but statewide for all young people 0 to 25, regardless of where you live, regardless of who your insurer is, or if you're uninsured, regardless of your immigration status, all young people 0 to 25. So why are we doing this? This is a slide that for many of you probably isn't needed, but we believe it pays off to serve young people. I think I often talk about pediatrics as the ultimate form in adult preventative medicine. And we know that investments upstream early in the disease course, early in the life course of our citizens can make a major dent in the lifetime of problems and challenges. We also know with behavioral health conditions, mental health in particular, that over half or nearly half of diagnosable mental health happens by and is recognizable by the age of 14 and 3/4 by the age of 25. So why are we focused 0 to 25? This is why we think that by having a world-class system available to all, we can change the true arc of lives of not just young people, but our adult and future leaders as well. Currently, we have too little of a focus on prevention. We have too few programs, especially in the case of substance use disorder, too few professionals trained to support this. And I mean professionals across the continuum, not just child psychiatrists, not just nurse practitioners or others who focus on more acute needs of young people with behavioral health conditions, but I'm talking about peers and behavioral health coaches and people with lived experience who can support our young people in focusing on their emotional well-being and wellness. We know that there are glaring inequities in behavioral health service delivery. We're going to take those challenges on, create programs to make sure that we're focused on low-income, overlooked communities, that we're paying attention to racial dynamics in our state, LGBTQ issues, and the needs in the unique needs in those communities, and of course, a focus on adverse childhood experiences, partnering closely with Dr. Burke Harris, our State Surgeon General, on so many of these issues. So what does this new ecosystem look like? It starts with sort of, and hopefully we create the most vibrant welcome mat you can imagine, wherein we normalize and create a wide open door for people to come through a virtual platform connected to a statewide provider network that will allow us to get young people timely services in their language, and ones that they can depend on. But that won't be the only solution. I like to imagine behind this door a series of rooms with large tables with lots of young people getting their needs met based on what they need. This is going to be, we often talk about school-based services, and I think a component of this will be school-based, but I like to also talk about school-linked services. We know today, not every school, and schools in particular in lower income communities, don't have all the resources they need either on the professional side or the facility side. So we want to make sure that even in those schools where that is absent, that there are a number of resources and linkages to this virtual platform and the plethora of services behind this door. It's going to connect to these behavioral health counselors and coaches. Some will be on school campuses, others will work virtually with school personnel. It's for commercial health insurance clients as well as Medi-Cal. It will have a component of a broad e-consult service for all primary care and other pediatricians, family practitioners, internists who take care of young adults, to make sure that we are equipped with a lifeline to immediately get the help that we need in supporting the families that we take care of day in and day out with behavioral health needs within our pediatric practices. It focuses on workforce, it focuses on evidence-based programs, and we'll have a component on facilities as well. So here's the breakdown of where this $4 billion is thought to go. About $680 million going to create this behavioral health services virtual platform, again, for all Californians all the time, connected to a whole network of providers and health professionals who can provide virtual services, help navigate and monitor and support individuals using the virtual platform. We are making a significant investment in infrastructure, the human capital side of health plans, county mental health plans, community-based organizations, and I said earlier, schools. Developing and scaling up evidence-based programs. We have a lot that we can steal and borrow from others. We have a lot of homegrown California programs that are strong, have a strong evidence base, are emerging and getting supported by evidence, but we also are going to have an ability to create more programs in this space so that we can remain iterative and recent and innovative with what we not just attach to the virtual platform, but also what we put in some of the brick and mortar facilities as well. Building the community continuum as well. This includes dollars, and I've heard loud and clear from directors of children's hospitals up and down the state, the need for more inpatient beds, for more urgent care emergency type resources to take care of young people in acute crisis, and then also more outpatient and community-based services. So this is building up the infrastructure, the brick and mortar buildings to support this emerging workforce that I will talk about in a second, to make sure that we don't just have a virtual dependence for services, but we can actually deliver things face-to-face. We will, in this current 5-year plan, have about $800 million to enhance Medi-Cal benefits, and much of the ongoing funding will be supporting their dyadic services, those family, adult, child services, focusing on strengths, focusing on assets, really meeting families where they are, receiving significant infusion of ongoing dollars, continued work on ACEs, adding dollars for promotoras, and on early maternal behavioral health as well, trying to give our youngest Californians early, fresh, good start as well. Significant component of investment, the next two together on workforce. This includes behavioral health counselors in schools, what we talk about as behavioral health coaches. This is a type of workforce that has been used successfully in other nations, really not peers per se because of the age of some of the clients that will benefit, but individuals who understand communities very much in a promotora-like model, but with a strong behavioral health background and understanding. And then the traditional capacity along the behavioral health continuum, looking to really redefine and rebuild the workforce for young people, with nearly $900 million going to through the state and my agency, but to education partners in the UC system, the Cal State system, the community college system, and others to build up this workforce that looks like California, speaks the language of California as well. I alluded to a broad scale set of efforts to support pediatric primary care, other healthcare providers with e-consultation, making sure that whatever patient and network is in, that you can use this tool to get immediate help, a warm line of sorts on children's behavioral health issues to help support each of you in your continuity practice and hopefully your future practices as well. You can't do this without a strong public education campaign and a focus on change, ensuring that we do what we can on changing the view and expectations of Californians as it comes to behavioral health, especially for young people, normalizing. I can't tell you how many times and how usual it is for young people to step up in class and say, you know, teacher so-and-so, it's time for me. My mom's picking me up to take me to my pediatric visit. I have to go. But that doesn't happen on behavioral health. Nobody stands up and says, sorry, I'm going to my monthly behavioral health appointment. How do we start to normalize it and change it so that it's not just the unexpected, but it's the expected condition of California that we provide that behavioral health support. And then as in every big, messy, hard to do, but worthy project in California, for a state with 40 million people as big as we are, we need solid, strong coordination. I'll have the privilege of helping play that role at my agency, bringing on a lot of consultants, subject matter expertise, hopefully some of you to help consult and tell us where we can go better, what we need to look out for, and then bringing on a strong piece of evaluation. That $50 million is the start. We know it will probably take more. It will iterate over time, but together this $4 billion of investment is something that the state has never made in behavioral health, and frankly, no state has. Even the federal government, who's making enormous investments, has not been this focused at this magnitude on children's behavioral health issues. And when we talk about it with our national colleagues, I think there's a bit of envy that we have a chance to create something here this comprehensive and this deeply invested in. I'm going to wrap up in just a minute. I'm just going to fly through these last couple of slides to emphasize, statewide, again, this virtual platform meant to really meet young people where they are. Just go down for those health financing wonks listening in. This might be one of the first opportunities to really talk about a unified financing approach for a single service. People talk about single payer and trying to bring all of the resources together, consistent payments. I don't want to go that far quite yet, but really unifying the financing on children's behavioral health so we don't let administrative barriers get in our way. That is another goal or objective of what we're trying to put together here statewide. I've mentioned a bit about the e-consult, e-referral system that we hope will benefit all of you in your day-to-day practices, tools that help you navigate and get through some of these important resources, but also to connect to other unmet needs, whether it's in the housing or food space. We know so much of the anxiety and stress and trauma young people experience is in their communities, but also has to do with more their own individual social condition. And how do we begin to change those conditions as well as we look out for the specific behavioral health needs of younger Californians? The workforce piece here, just emphasizing that what we want to see are classrooms, either virtual or in person, full of people who look like our state, brown and black professionals who choose behavioral health and children's behavioral health as a profession, building up the substance use disorder services network that is frankly lacking. I can name on one hand the high quality substance use disorder programs for young people in Los Angeles. They are not enough. We need more, and we need them to meet young people where they are. Again, in this, for those hospital leaders on the line, I know dollars and investing in some of the potential services for building up beds and those network of facilities that we need. I hope to see not just 8 children's hospitals proposing how to use those dollars to build up beds, but coming together in networks in collaboration with community-based organizations to build community models to meet the needs of young people. I don't think any of us expect every young person to end up in a locked psych bed. That is not what any of us dream for. So we need to be more upstream and build that continuum up in a thoughtful way. We went through the dyadic services and the Medi-Cal investments, but I think this is worthy of its own conversation, and happy to engage with many of you in the future on those issues. Again, I underscore this normalized concept. It's something that we talk a lot about. We need to figure out ways, innovative ways, ways that we communicate, ways we use our public health campaigns, ways that we build momentum to make sure that people see behavioral health as a normal part of what we do, the ups and downs as normal, and the ability to get help as not just normal, but something that we are all expected to do and need throughout the course of our life. So what do I need from you? And I'll never, and those of you who know me will know that I try to get us all to work and do something to push forward our collective agenda. But I think we want to hear what you advocate for and what you think we should be doing in this area. I hope that you'll contribute what you've experienced both anecdotally in your own experience on the wards or in your clinical practices, publications that you'll be working on, or just anything that gets triggered from your own community walk. We expect that your antennas are up higher than so many others, and I look forward to hearing your idea. And then lastly, and very concretely, every project in the proposed May revision is not done. We are still in a proposal phase. We are still working with legislators to make sure that this proposal comes out intact in a way that lets us put our best foot forward. And if you're so inclined, take a look and see who your legislator is, send them a line and say, this is important and this is why, and who you are and why it matters to you. And those letters, I think sometimes we forget what an important difference they can make. And I urge you that if you're interested to do it, not just for this issue, but for so many into the future. I think that's the end. I'll stop sharing, and then hopefully now, let me get off this quick. Sorry. As I'm doing that, Meg, I'll turn it back to you.
Terrific.
And have you go to some Q&A.
That sounds great. So first of all, Mark, getting a lot of shout outs here from your fans who have been working here over the years. And I wanted to mention that certainly our experiences, both as primary care providers and as subspecialists, definitely mirrors what you've talked about related to the serious mental health and behavioral health conditions that you cited. And Dr. Forsberg had put into the chat that the inpatient census for the eating disorder stabilization unit has doubled over the course of the pandemic. And so, but just in general, in recent years, we've seen growing numbers and a huge exacerbation over the last year. So to the first question, Dr. Joanne Jung, who's one of our developmental medicine docs, points out that we have a child and adolescent psychiatry portal, which provides real-time psychiatry consultative guidance to primary care providers for youth and with mental and behavioral health concerns. And the fact is that right now it's dependent upon philanthropy. So she's wondering about options for state funding to help support programs like this, and whether there might be any state governmental partner to in applying for a HRSA grant to try to fund this kind of a service, so it wasn't at the whim of philanthropic support.
I mean, absolutely. I've heard about that tremendous work. I think something like this needs to be scaled. I've challenged some of the UC leaders as well as the other children's hospital leaders to really come together. What I'm imagining is maybe UCSF is running the portal from 8 to 5. Another facility is running it from 5 to midnight, and another one has the midnight to 8 shift. And that we build a network across the state to really manage this. So it's great work that has started, and I think that's exactly the kind of program that we want to see this funding go to scale up and increase, and hopefully we'll have a chance beyond this to have those conversations.
Great. Another one of our faculty, Dr. Richard Quint, says that many of us remember the days when schools had sufficient numbers of nurses and counselors to serve communities, but these disappeared. And he's wondering about the plans proposed for new services going forward to be permanent, so that they're not vulnerable to cutbacks, which has such negative impacts on children and youth.
Yeah, I mean, our work and why we're making such an investment in training is that we can build these up and have them be ongoing resources. I too remember those cuts and lament them. I know that schools, wherever they are, have been struggling with finding not just trained professionals, but professionals they can afford and pay to do this work. And so both in the work on the behavioral health proposal I've mentioned, but the broader package of school investments that the governor's making is meant to support those positions. It's always hard to say permanent, how many years that means, but for the foreseeable future, an expectation is they will be part of what young people should expect and families should expect on school campuses, hopefully building up as quickly as we can, but it will certainly take a little time to bring that workforce back.
Great, thank you. And I'm going to batch a couple of these questions. One from Dr. Peggy Weintraub, who starts off saying, "Wonderful talk from a previously wonderful resident." Her question is related to another that was posed by one of the psychologists who works here at BCH. And the gist of it is that funding for behavioral health services is one thing, but they're wondering about the investment in the training and supply of behavioral health providers, because of the fact that it's difficult to find the appropriate providers. In the current situation, the workloads are just unsustainable. They're staggering, and people often choose private practice because of reimbursement issues and the workload in the public sector. And so I think the question is really about where will these providers come from, and trying to think about how they will be trained up.
So, I mean, this is an important and critical question. And as I mentioned, about $900 million of the one-time funding is going into training. It's going to be used to build out a continuum of providers, both on the most sort of highly trained, whether it's child psychiatrists or other behavioral health professionals that go through rigorous training programs, or what I like to think of as community professionals, people who use their understanding of communities, the local issues, and receive some training to support. So building up a full continuum, we dream of at least adding 5,000 to 10,000 new behavioral health workers on the children's health, mental health side over the course of the next 5 years. This is going to be hard work and important work. Some of it will focus on child psychiatry, and others will focus on the other end of the spectrum. And so not only is this about the funding for the care, but it really is building up the workforce. And we have taken that very seriously. We hope to be partners with the UCs and other important leaders on medical education, clinical education to build these programs, not just what the programs teach and instill, but where they happen and how they happen so that we recruit people from all across the state.
Thank you. Dr. Maisel is wondering about mental health carve-outs and how that they might factor into your plan, citing that they've been a major driver in the loss of mental health services accessibility. And why should insurance premium dollars be given to companies who don't reimburse providers a living wage? Is there any way to influence who's able to participate in these kinds of services and how the reimbursements will go?
Yeah, I mean, so first off, California, not unlike other states, behavioral health conditions have been historically carved out. We do that in many, many different forms, even in Medicaid, for more significant needs, it's carved out and done at the county level, wherein what the quote mild to moderate needs are taken care of through the Medicaid managed care plans. So really working on understanding the pros and cons of those approaches, making sure we leverage existing work at the county level is going to be key here. But one of the key departments that I have the privilege of helping manage and lead is the Department of Managed Healthcare. And they play a leading role with our commercial plans, and not just what they pay, but how they pay and who their provider networks are. So this is going to be, in many ways, parallel efforts, one of which is focused on working with our commercial plan partners to ensure that not just our rates fair and to the point around living wages that are focused on paying that, but also ensuring that the coverage and the amount of care is adequate to meet the needs of all young people. So we have our work cut out for us. It's pretty ambitious, as that isn't often the approach, but it is one that we have taken as a foundational principle to this effort, working with not just the public, but the private commercial plans as well.
Thank you. Here's another question from Dr. Rob Goldsby, who remembers you fondly from the Red Team. Shout out to you for
Yes.
the amazing job that you're doing. His question is, I hope that I will be able, that you will understand this fully, because I'm not entirely sure that I do, but it's a question, what's the impact of, quote, non-social media on increasing emotional disturbances? And are there any initiatives to assess and address this? Perhaps maybe related to the vitriol in the general media and the impact that may have on people's behavioral and mental health.
Well, I think, area that I don't, I would never claim to be an expert on, but I can say throughout this entire pandemic response, one of the lessons learned that I have is we all need a bit of media training. We all need to understand how the press and communications and the media in general drives our understanding of a public health emergency. And behavioral health is going to continue to be a public health challenge, if not crisis and emergency for us moving forward. So how do we begin to train and support families to understand and young people understand the role of social media and sort of mainstream media in driving behaviors, driving impressions, driving the normalization, if you will, of behavioral health. So I think this is an area where we have an opportunity through these resources and services to begin to think about that. And if there are specific ideas that where this comes into play, we have a significant amount of funding targeting the outreach, engagement, and media campaign, that we would love to hear those ideas as part of your contribution. Whomever it was that asked the question, would love to hear your thoughts on it as well, either here or down the road.
Yeah, so that was Rob Goldsby. So
Oh, it was Rob. Yes.
yeah. So I'm going to go quickly to the chat and just point out that Dr. Anda Quo, who was your program director in Plus, says, thank you, Dr. Galley, for your leadership. Grand Rounds is perfectly timed. And I will just let everybody know that you can look in the chat and see the Google Doc that she has posted, because she is involved with a campaign right now to advocate for funding for children's mental and behavioral health services. So if you, there are lots of details in the chat, which I won't take the time to go into at this moment. Dr. Hammer asks, in this acrimonious political climate, will you run into difficulty guiding this process through state legislative approvals? I've been wondering the same thing about, you mentioned to me that it's not through yet. So what's the timing and what can we do?
Well, I mean, my last slide sort of said it. We have a few weeks to go. We'll know, not even a few, probably a couple more weeks. I'll tell you that there's been many positive recommendations on the proposal. The devil's in the details, as they say, something this big. I think a number of people are worried that it's too complicated and too large. And I often say, well, it's as complicated as large as the problem is. Like less than this kind of investment is probably not going to be sufficient. So we know what we're biting off, if you will. And I think we need to do a good job communicating to the legislature why this is important. So I'm worried too. I'm always concerned until it's done, but we will continue to put our best foot forward. And those daily conversations I have the privilege of having with legislators, explaining the details, explaining that, yeah, we don't have everything figured out yet, but we're going to bring the best minds in California, including some of you here today, to help us think about it. I hope is going to carry the day, and I'm optimistic, but I hope each of you will decide, hey, this is pretty important. Let me take 10 minutes and fire off an email to my legislator reminding them of how important this is. And you may be talking to somebody who's already there, and you may be talking to somebody where your letter makes all the difference. So that is a place where you can help immediately.
Point taken. Thank you. Great advocacy. So we have a couple of providers from the general, Dr. Clem Donahue, thanking you for your work. And he's talking, asking about the different needs between mild and moderate disease and also moderate to severe disease, which is also echoed in the question from Dr. Tanya Chafee, because one of the issues is that for the youth with more moderate to severe mental health issues, they're not necessarily appropriate for care within the scope of primary care. But there are so few resources available both on a state and nationwide basis because of the number of child psychiatrists available. She's just wondering about if there's been discussion about working with adult psychiatry to get some retraining for some of these so that they can extend to the adolescent populations, and also possibly some incentives to help those folks work with lower income populations, like student loan repayments or other kinds of bonuses.
So Tanya and Clem, yeah, all of the above are under consideration, and I hope we can sort of tape your question and in 5 years ask it again and say, we really use these investments and this opportunity to turn that reality around. I think if we're successful, one of the points of success is that not that we have more than enough, but that we have sufficient infrastructure, people, and buildings and other tools to meet the needs of young people with severe behavioral health conditions. And part of the reason why we know they become severe is because we fail to treat them early. We fail to be attentive early. And I think this is an opportunity to be upstream in a thoughtful way, while also building the capacity downstream for the more significant behavioral health conditions that I know many of us face.
Okay, there are many more questions than I'm going to be able to get to here, but we have one from Dr. Ayana Bennett, who says that she's now working for the San Francisco Department of Public Health and working on operationalizing racial equity. She knows that that's a priority on the state level and is asking about guardrails or innovative practices being instituted to ensure that the funding actually addresses those inequities.
Yeah, I think a couple of things immediately, right? So first off, this workforce investment, it is not just, and I know the concern around the adequate supply of child psychiatrists and other people on the acute end of the spectrum, but how do we make sure we build up an army of people that are attentive to young people's needs in our communities, that look and speak the languages of our communities? And that is, to me, going to be one of the hallmark drivers around our equity principles, around closing disparities, and frankly, ridding ourselves of some of the structural and racist issues within our healthcare delivery system. So working on that, I think this is unlike other programs where we're playing around the edges. We get to, in many ways, build a brand new workforce. And I think it will be up to us to make sure that it's cast in a way that allows us to see equity and delivering on equity in the future. And then the media campaign, the outreach campaign, I think we need to make sure that it's not one size fits all, that we use the opportunity with not a small amount of funding, over $100 million in this space statewide, to really drive something that I think relates and interacts with all parts of our young populations and is built by young people. The role of young people and their voice in creating this, I think, is also going to allow us to not overlook some of the equity considerations that, when in the hands of adults alone, we often fail to do the right thing.
Thank you. And I'm going to put one, I know that we're out of time here, so I'll just say that we have an amazing educational psychologist, Mel Callan, who's over at the General, and she's really advocating for a way to facilitate communication between pediatric providers and schools, because so many things stall because we can't adequately communicate with each other. And she's wondering about advocating how to push for interagency collaboration. And I'm just going to say, right to our representatives and our, because I think we're out of time. And I know that you mentioned to me before that you are ready to go back to back when we get off of this grand round. So I want to say again, I wasn't able to communicate all the shout outs and everything from the chat, but you are very well loved, very highly respected. We deeply appreciate you spending the time with us today, and we're all going to get onto our email and do what we can to get your proposal passed.
Beautiful, and really a privilege and an honor to be back with all of you. And it's great to see the names fly through the chat, and really grateful for all that each of you has done, and look forward to working with you on this proposal, but so many other things to advance sort of the opportunities for young people in California.
Thanks very much, Dr. Galley.
Okay, be well.